Okay. Sorry to the crowd. You can hopefully hear me now. So a little bit of background of why we do ACL surgery to begin with. So this is a study from probably 20 years ago now. A friend of mine, Warren Dunn, who I trained with, went back and looked at ACL injuries in the Army over a 9-year period. They had 200 ACLs. And they found that about 10% of those people in the Army that had an ACL actually were permanently discharged because of lingering effects from their ACL. What do we know about ACL injuries? So this was slides that I witnessed when I was a resident 25 years ago. Stefan Lomander came to our department as a visitor. He talked about ACL injury and surgery. Put up some numbers of the risk of developing osteoarthritis in your knees, about 50% at 25 years if you've had an ACL injury. He said the data was really poor and we couldn't justify that ACL reconstruction made a difference in that prognosis or not. So those were just, and these were all different studies that he kind of scatter plotted up there for us to look at. Another study by Warren Dunn on the military, 6,500 ACL injuries in the military. It was almost 50-50 of how many had surgery and how many didn't. It wasn't randomized. It was just purely decisions made on the part of the physician and the patient. What they found at the rate of needing surgery for other things besides their ACL went up by 3 times if they were treated without ACL reconstruction. Their chance of tearing their medial meniscus was 2.3 times higher, cartilage injury 2 times higher, and any other surgery 3 times higher. So there was some conclusion based on that retrospective data that ACL reconstruction is probably protective against meniscus and cartilage injury in the future. Which brings us to MOON. So what is MOON? MOON stands for Multicenter Orthopedic Outcomes Network. It was started in 2001 at 7 centers across the United States. 8 surgeons, now it's up to 20 surgeons. So those participating sites could add people as they added faculty. What's the benefit of being multi-center? Well, you increase your sample size. 20 years ago when this started in 2001, most of the ACL literature was level 4 case studies. So single surgeon or single center ACL, 100 patients here, 50 patients there, 200 patients here, somewhere else. So with multi-center, you just automatically kind of start to increase your N. The other thing is that, relatively speaking, the outcomes of interest in ACL, arthritis, re-rupture, and some of those things, those outcomes aren't terribly common. So the more numbers you have, the more likely you are to be able to pick up a significant number of those outcomes of interest. And it's more generalizable. So if we only have 100 patients of Dr. Gatt, we only know how the outcomes are with Dr. Gatt. If we have 100 patients of 20 different surgeons across the United States, it's probably a little bit more generalizable to the orthopedic community as a whole. And the goal of MOON was to get a prospective cohort to determine the impact of ACL injury and surgery, and also analyze all those risk factors. The more patients you have, the more risk factors you can analyze for success, failure, and ultimately osteoarthritis. So these are all the different sites that were participating, kind of all across the country, all academic sites. These are all the support staff that were involved over the years. It's been well funded. So Kurt Spindler at Cleveland Clinic has been the driving force behind MOON Knee. And he was awarded an NIH R01 grant, which was re-awarded several times along the way, to the point that we're now kind of going for funding to try to get 20-year outcomes of the ACL cohort. So how did it work? Every ACL patient that any participating surgeon was operating on was made to fill out a patient form. We were chastised immensely if we did not include all of our patients. So we didn't want any non-inclusion bias to be part of the study. That was tracked. So every patient was supposed to be enrolled. There was a 50-page paper form that we would fill out after every ACL that we did, that gathered about every detail that we could think of at the time relative to what happened during the surgery and what we found and what we did. The patients also filled out a lot of questionnaires before surgery as well as after surgery. And then they were followed with phone calls to see if they had any further surgery or injury, and also to get their patient-reported outcomes as they were going down the road at 2 years, 6 years, 10 years, and now at 20 years. And we, as a research group, would meet the first Monday of every month at 6 a.m. on the phone. And they would go over how your numbers were looking. What was your follow-up? Did you need to call any of your patients to get the data back? Because they would kind of go through this algorithm of the research assistants and staff trying to get a hold of the patients for their PROs. And if that didn't work, then it was on us as staff to call them. So I would call my patients or email them or text them to try to get them to fill out their forms. So here is the enrollment over the years. We ultimately ended up enrolling over 3,500 patients. And at 10 years, we had data on 82% of them. We had over 90% follow-up by phone. So some of them would talk to us on the phone, but then they wouldn't send in their forms. As we started all this stuff, there was a fair amount of work done to try to validate what we were doing. So as you can imagine, anytime you get more than 2 or 3 orthopedic surgeons in the room, they don't agree about a lot of things. So we wanted as a group to agree on how we would describe things. So we would actually do videos, look at meniscus tears, and try as a group to come up with a consensus of this is how we're going to describe this meniscus tear, so that when we enter all this data into the database, it's not a bunch of gibberish or different opinions on those things. So we did that with both meniscus tears and with cartilage injuries. And that was a couple of the kind of pre-study validation studies that we did. We also did systematic reviews on grafts, BTB versus hamstring. Quad tendon wasn't really a thing back there, so that wasn't in there. Allograft was starting to come out, but we did systematic reviews as well to kind of look into what grafts and so forth that people were using at the time. And at the time, there was no difference that we could find in the literature, BTB versus hamstring. A lot of this was also some validation research that I was tasked with. So I was one of the junior members when I joined back in 2003. And this is also when Freddie Fu and the Pittsburgh group was really pushing anatomic ACL. And there was a big push of where are your tunnels? So are you putting the ACL where it needs to be? Is it anatomic? And so I was tasked with kind of surveying our group. So we spent one day in San Diego at Donjoy. They donated like 90 cadaver knees. And I had 12 of the orthopedic surgeons do ACL tunnels on 6 different knees. And then we did x-rays with fluoro, and then we got a CAT scan. And then we also followed 100 patients in the cohort with postoperative x-rays and CAT scans to analyze where our tunnels were. And basically we came up with, there's pretty small variations surgeon to surgeon, no matter if you do an independent drilling or 2 incision back in the day, which would be a flip cutter now, whether you do medial portal or if you do transtibial. So there's some slight differences. We didn't think they were clinically relevant, but it was kind of, hey, we're validating that the group actually puts the ACL where it's supposed to be. So what about some outcomes after ACL? So let's talk about patient-reported outcomes. So here's 10-year patient-reported outcomes on the first 1,500 ACLs that were managed. You can see the group was about 50-50 male-female. Basketball was the most common sport involved when people were hurt. About 40% of our cohort were in high school. And the breakdown for grafts was 42% BTB, 31% hamstring, and actually quite a bit of allograft, 27%, which was quite common in the early 2000s. And what we found is that there was a significant improvement in the outcome scores that we use. So the IKDC was developed by AOSSM and some of the other groups. That's a very common sport-related outcome measure for knees. KOOS is more European, but also bigger. So the KOOS score. We found improvements in all of these outcome measures at 2 years, but we also showed that they maintained themselves at 6 years, and at 10 years, they never reached normal. So if you look at this graph, so the injury data, their PROs is the purple line, and then green, red, and blue is at 2, 6, and 10 years of their PROs after their ACL reconstruction. So you can see they have a significant improvement. It never gets to normal, but they actually don't drop off over 10 years, which is pretty impressive. You would kind of think some of these things would start to drop off, but they've maintained themselves quite nicely. This is just looking at IKDC itself. You can see it's stable. We use the Marks activity scale. So Bob Marks is at HSS. He's one of the members of the Moon group. He developed this activity scale. If you have an activity scale of 16, you're probably running in place while you're listening to the lecture. And if you're a 0, you're probably still at home laying in bed and haven't moved in a week. So that's kind of the bars of the activity scale. And not surprisingly, very active people when you tear your ACL. You're younger, you're more active. At 2 years, you've probably slowed down a little bit. At 6 years, you probably slowed down a little bit more. And if you were 22 when you tore it, now you're 28 and you're working, you're slowed down a little bit more as well. So activity does decline over time, but we would mostly relate that to age and kind of change of activities overall. So what are the risk factors for having lower outcomes down the road at 10 years? If you had lower PROs when you tore your ACL and we asked you to fill out the forms before surgery, if you had kind of a low PRO, you were probably going to have a low patient-reported outcome at 10 years. So that was probably the most significant thing. Some people just kind of don't feel like they're doing very well, no matter when you ask them that. And that carries through even after ACL injury. If you have a high BMI, if you're a smoker, if this was your second ACL, or if for any other reason you had another surgery on that knee, you were going to have lower PROs. Those are the things that stuck out of 50 to 60 risk factors that we would analyze in lots of patients over the years. We did look into some other things, as you can imagine. So we took a subgroup of 675. We collected their neighborhood socioeconomic status to see how that affected things. And we did show that lower socioeconomic index was associated with lower outcome scores. And that was a little bit of correlation with age and education as well. Meniscus treatment. So if you had a normal or untreated stable meniscus tear, your joint space at 2 years didn't change. If you had a medial meniscus repair, your joint space got a little bit narrower by 2 years. If you had a medial meniscus repair, there was narrowing, but it was a little bit less than if we had excised the meniscus. And this is getting into some of the arthritis data that hopefully over the next few years will become a little bit more evident. So Morgan Jones, who's was at Cleveland Clinic, now I think is at Brigham in Boston, is driving a lot of the radiographic follow-up of these patients to look at arthritis. All right, we're going to talk a little bit about graft choices, re-tear rates, risk factors, and those kind of things. So this was some very impactful data that Chris Kading at Ohio State, who I think has been here in the last few years, he's a part of Moon, and he looked into the whole allograft issue. As I mentioned, in the early 2000s, allografts were very common for primary ACLs. They're quicker. It was readily available. There were a lot of upsides of using allograft. What we found is that if your risk for using or having a ACL graft failure at 2 years, your risk of re-tearing was 1 to 6%. If it was using an autograft versus 2 to 20% if you had an allograft. If you were 18 years old, your risk of re-tearing your ACL within 2 years with an allograft was 20% versus 6. If you're 40 years old, it was 3 versus 1. So it's very much driven by age and activity. It's about 3 to 1. And it kind of this slope, this graph that you can see, just depending on age, you start to get out to 40 years old, it probably doesn't make any difference. 3 versus 1 doesn't matter. If you're 16, 20 versus 6 makes a big difference. That's a bad deal. So this literature really kind of changed graft usage in young people who are still active. We took a bigger sample, so almost 2,500 ACLs, 93% follow-up. In 2 years, 3% of them had torn their other knee. 4% had torn the same knee. The risks of tearing one of your ACLs was lower age and higher activity. So there was an 11% increase in your risk for every activity level point that you're more active. And there was a 9% lowering of your risk for every year older that you got. Pretty significant kind of interaction there with age and activity. And if you had an allograft, you were 5 times higher to tear your ACL than if you had a BTB. So at 10 years, your risk of tearing your ipsilateral ACL is 8%. Your risk of tearing your contralateral ACL is 9%. So within 10 years, most of your patients have about a 17% chance of tearing one of their knees. Again, very much driven by age and activity. How about high school and college aged athletes? So we looked at 770 patients that were 14 to 22. We compared BTB and hamstring. It was about a 50-50 group, males and females. We actually had 64% of the group, this part of the cohort was a BTB and 36% was a hamstring. 33% of these people had what we consider to be high-grade laxity. So high-grade laxity was considered if you had a pivot clunk in the operating room, like you can do a pivot shift, but sometimes you do a pivot shift and it's gross. That's a pivot clunk. If they hyperextended by more than 10 to 15 degrees, or if they had a very dramatic Lockman, that was kind of considered to be hyperlaxity. So the ACL graft tear rate or ACL tear rate over 6 years was 20%, 9% on the same knee in this group, and 11% on the contralateral knee. The risk of tearing your ACL graft was 2 times higher with a hamstring graft compared to a BTB. And I would tell you, as a member of the group, there's a bit of a bias in the group. You could do whatever graft you wanted. I think most of the people in the group would do a BTB for who they considered to be their higher risk folks to begin with. So even with that in place, it was still 2 times more likely to tear your graft if you had a hamstring. And the risk factors were young age, high grade laxity, and graft type. And that was really the first study that we've been able to show that would show a difference between hamstring and BTB in an active population. So that was a relatively important study for us as a group to put out there. Effective high grade laxity. So I talked about this. If you have a Lockman or a drawer more than 10 millimeters, if you have a grade 3 pivot clunk. So these high laxity patients have about a 2 times increased odds of re-tearing their knee. This was Bob Magnuson at Ohio State that analyzed this stuff. What's your rate of returning to football if you tear your ACL? In high school and in college, it's only 70%. That's lower than what we thought. We thought it would be higher than that. Of the folks that didn't go back, 50% of them cited fear of re-injury as the main reason that they didn't go back. The rate of return to soccer is actually the same, 70%. Again, we think we do better than that, or at least I thought we would do better than that, but it's only 70%. Males are more likely to go back than females. So other outcomes, things that we don't like to talk about, complications or further surgery. So we talked about some of these risks to the same knee, 2 years, 6 years, 10 years, 4.9, 7.7, 8%, contralateral knee, 2.5, 6.4, 9%. What's the risk of an infection? It's actually quite low. It's less than 1%. Risk factors are diabetes. If you look at the graphs, there's difference in rate of infection based on graft. So your BTBs are going to be your least likely to get an infection, followed by allograft, followed by hamstring. Thought process there is the hamstring has more surface area. You probably have 4 or 5 strands, just more surface area for something to be contaminated. There's also a lot more work that goes on with hamstring grafts, typically on the back table, than what happens with some of the other grafts. What's your rate of needing another knee scope for scar tissue or arthrofibrosis? It's about 1 in 20 over 6 years. And the rate of having some kind of hardware removal is actually quite low. A little bit of dabbling into types of drilling. So transtibial ACL, which again was very common back in the early 2000s. We did have a lot of surgeons that were doing 2 incision ACL and also some doing medial portal. We just found that there was a higher risk of undergoing further knee surgery if you had had a transtibial ACL. What causes pain? So there's a subset of patients that just continue to have knee pain at 6 years out after their ACL. And the most dominant risk factor for having knee pain is they either had a revision ACL or they had another scope of some sort. We couldn't find any drivers in terms of demographics or articular cartilage. Those things influenced knee pain, but it wasn't as bad as just having to have further surgery. How about other things that happen? So meniscus tears and cartilage injuries are very common. So if you tear your ACL, I always kind of like to think about it. It's either an ACL case or it's an ACL plus or an ACL plus plus. So like, I like taking care of the ACLs. I don't like the ACL plus 2 meniscus tears plus a cartilage. And those are just 2 totally different animals. We find that about 45% of patients in our cohort had a lateral meniscus tear, 37% had a medial meniscus tear. The rate of having some kind of cartilage damage, medial compartment, 24%, lateral compartment, 22%, patellofemoral was 22%. We looked at our success rates after meniscus repair. So this is something that I took on for the group with Robbie Westerman, who was a resident, now one of my partners. The first 286 patients that had a meniscus repair with their ACL, success rate was 86%. It was found to be the same medial and lateral. Most of those repairs were done using the all inside technique. There was a subset of inside out repairs. which we were talking about last night at dinner a little bit, the painful long needles and, extra incisions and those kind of things, that little subset actually did quite a bit better than our all inside repairs. We also looked at a subset of patients. We find meniscus tears sometimes that we just don't think we can make better by trimming it or fixing it. Maybe we just ignore it. Aggressive non-treatment. Don Shelbourne used to talk about this group, aggressive non-treatment of the meniscus, especially on the lateral side of the knee. And we had 200 of those tears in our ACL cohort. And at 6 years, we found that 94 to 98% of those tears never presented a problem. They have subsequently gone back to look at meniscus repairs with a larger group. So we had 200 patients in the paper that we put out. They've subsequently gone back and looked at 650 patients that had a meniscus repair at 6 years. They found the failure rate has gone up a little bit as they increase the numbers in the group. The repair failure rate was 8% of lateral tears and 18% of medial tears. And there was a little bit of influence of what kind of graph they had put in at the time. Some of this is going to be related to our failure rates were lowest with PTB, they were highest with allograft, and they were somewhere in the middle with hamstring. So you're more likely to have a revision or have another operation. But just, I would say, keep in the back of your head that medial meniscus repairs in the setting of ACL surgery probably 2 times more likely. We dug into this a little bit more, just looking at a systematic review of meniscus repair, 5 to 6 year follow-up. All inside failure rates, very similar to what we reported in our first study, 16%. If you do an inside out kind of classic incision, usually put more stitches in, but the failure rate goes down to about 10%. Jeff Neppel and Rick Wright at WashU looked at 13 studies with meniscus repair in the setting of an ACL or in the setting of on their own. There's this constant kind of dogmatic thing. Meniscus tears heal better in the setting of an ACL reconstruction. It actually doesn't bear out in the literature. So your meniscus repair failure rate in the setting of an ACL intact knee is 22% would fail based on the literature. If you had an ACL plus a meniscus repair, it fails 27% of the time. So a little bit of this dogmatic thing that we've all been taught, or sometimes is still preached, it actually doesn't bear out in the literature. How about root tears? So we do see a high incidence of lateral meniscus root tears with an ACL. This is not Moon data, but Bertrand Sonnery-Cote is over in Lyon, France, and he's done a lot with the Santee group. So you hear about the Santee group as an ACL reconstruction group. He found about a 6% incidence of lateral meniscus root tears in the setting of an ACL. And the risk factors for that, we're having a contact ACL, we're having a concurrent medial meniscus tear. We don't have a whole lot of data about how they do when you treat them, unfortunately. So Rob Leprod, formerly of Vail, now back up in Minnesota, has looked at these and found that the success rate's about 95%. Ramp lesions. People know what a ramp lesion is. Ramp lesion is a tear where the medial meniscus meets the posterior medial capsule. Quite honestly, it's not something that we even talked about 15 years ago. Like, we don't have it in the Moon database because we just didn't think about it or talk about it. So we don't have Moon data on it. They were probably there. We probably didn't see them. But the same Santee group has looked at ramp lesions. They're actually, I look every time now, and I'm always disappointed when I find one because that's a little bit more work to do. But you can see the top picture. That's just a split. Your meniscus would be on the kind of the bottom left, and your capsule would be on your top right. And that's a split, kind of a very peripheral split of your medial meniscus. And they actually found the incidence of about 24% in this ACL group out of France. Risk factors for that: males under 30, revision ACL, chronic ACL. I would agree with that. Lots of laxity and a minimum of 2-year follow-up. 10% of these patients have had to have a subsequent medial meniscus surgery. And they're doing a lot of ALL augmentation of their ACL reconstruction. So they found that when they did that, the risk of having further meniscus surgery went down. So how does all this other concomitant stuff affect outcomes? So here's 10-year data from the Moon group. Risk factors for lower PROs based on structural stuff. We already talked about lower PROs at baseline, high BMI, smokers, revisions, any subsequent surgery. If you were found to have grade 3 or grade 4 cartilage changes at the time of your ACL, you're going to do worse at 10 years. If you had a lateral meniscectomy at the time of your ACL, probably going to do worse. If you had medial or lateral meniscus surgery prior to your ACL, you're probably going to do worse. Things at 10 years that didn't matter. If you had any kind of medial meniscus surgery at your ACL, it didn't matter at 10 years. It didn't affect your outcomes, which is interesting because that fluctuated at 2 years and at 6 years. There was a lot of influence of medial meniscus surgery on PROs. And at 10 years, it totally washed out. It wasn't important anymore. Variables predictive of poor 10-year PROs. This is Rob Brophy's study, kind of looking at specifically at articular cartilage. If you have patellofemoral joint or medial compartment grade 3 or grade 4 lesions, you do worse. The articular cartilage injuries appear to be more predictive of your patient-reported outcomes than the meniscus stuff. So if we were going to kind of, what's more important, would you rather have a meniscus tear or would you rather have a big chunk out of your femur? You'd rather have a meniscus tear than a big chunk out of your femur cartilage. Partial meniscectomy and meniscus repair did not seem to have a powerful effect at 10 years. So we do a lot of this work to try to head things off, but it's still kind of unclear whether or not us repairing a bunch of stuff or doing a bunch of cartilage surgery, if it's really having an impact yet. We haven't been able to wash that out. There's been some collaboration with the Norwegian and Scandinavia. So Norwegian and Scandinavia have big registries. So there's been some collaboration, and we always kind of like to compare what we have with the Moon Group, which is all US data, with some of the stuff that they get out of Europe. So this is data out of Norway, I believe, 1,200 ACL patients at 5 years and slightly fewer at 10 years. And what they were looking at is what changes between 5 years and 10 years after your ACL. There was a significant decrease in their PROs over those 5 years. And that decrease was seen if you had an ACL plus a meniscus plus cartilage injury. If it was just an ACL, they stayed pretty steady. But if it was ACL plus, like what we talked about at the beginning, they kind of continue to kind of trend down. If it's just ACL, they're pretty smooth and seem to stay pretty good. Other things that can happen with ACLs, we didn't have a huge number, but Rob Westerman and I looked at ACLs plus MCL injuries. We had 27. This was kind of early in the cohort. About 20% of these patients ended up needing another surgery for stiffness. We had some that were reconstructed, some that were repaired. We did not find a whole lot of difference with that. We had some that were just treated non-operatively. And again, there was slight difference, but not tremendous when you only have 27 ACLs. We did find higher patient-reported outcomes if we treated the MCL non-operatively and then came back and fixed their ACL if we worked on both at the same time. Same thing with posterolateral corner. So this was not this early on. We kind of included everything. We had some multi-legs in the cohort early on. Those kind of stopped being enrolled after a few years, but we had 34 ACL plus posterolateral corner. It was interesting. It was about 50-50 repair of the posterolateral corner versus reconstruction. You can see there was quite a big difference in the time to surgery. So the repairs were done in the first 3 weeks. And on average, the reconstructions were done when they were 3 or 4 months out from surgery. 6-year follow-up, we had no difference in the PROs. Everything actually kind of washed out to be pretty similar, repair versus reconstruction. Again, keep in mind, these were different groups, acute repair versus reconstruction in a more chronic setting. All right, last little section here, cost effectiveness of ACL reconstruction. So Chad Mather is down at Duke. He looked at the cost effectiveness of doing an ACL reconstruction early versus doing it later if they failed non-operative treatment. And he found that using, they used the Canon study, which is again out of Norway. This was a non-operative randomized controlled trial of ACL rehab versus surgery, as well as the Moon Group. And they found that early ACL reconstruction had both an increase in quality of life and a lower cost to society. So from a societal point of view, at least using his metrics and outcomes, there was an early ACL reconstruction is more cost effective and probably the preferred strategy. Warren Dunn and I looked at quality of life after ACL with 1,500 of the Moon patients. The mean gained quality adjusted life years after an ACL reconstruction was 5.3. Which is actually relatively high. So, It's generally considered in orthopedics that total hip replacement and total knee replacement are really big quality adjusted life year, they're impactful, and compared to things like a cabbage is only 0.3 at 6 months. A total knee is 0.6, a total hip is 1.3, a rotator cuff repair is 3.4. ACL reconstruction is very impactful in terms of quality of life. It's 5.3 quality adjusted life years. So back to our 21-year-old college linebacker. So here he was at surgery. We did find this peripheral medial meniscus tear that was fixed with 3 all inside stitches. He had torn his ACL. He had this delaminated 8 millimeter full thickness grade 4 cartilage defect on his medial femoral condyle. He had a radial split of his lateral meniscus that, at least on the inferior surface, went out to the capsule. Or repaired his radial split of his lateral meniscus. We did a little microfracture on his small little defect on his femur. We did an ACL reconstruction. He did well for about 1.5 years. ACL still okay. He retore his medial meniscus, unfortunately. So he had a partial meniscectomy at that point in time. His medial femoral condyles on the bottom right filled with fibrocartilage. His lateral meniscus is on the top right. Looks like it's healed relatively well from a radial tear repair. And he ended up continuing on and got through okay after that. So the Moon database has provided quite a bit of data on injury and surgery. We're still trying to figure out how things are going to do after 10 years. Things that we think have been important, the role of allograft. I think the group sorted out quite well. Graft choice in our young active patients, I think we've contributed to that. It's been nice just to kind of put numbers to different complications and other things that happen. And it was nice to justify that ACL surgery is probably worthwhile. There was quite a bit of rhetoric at one point in time in my career about why do we even do ACL surgery? But I think a lot of the metrics here would show that it's probably a worthwhile operation. So here's all the different funding that's been involved with this from a variety of different angles. And I'm going to open it up for questions. Thank you.
So I'll start off. Thanks very much. It was a great talk and very comprehensive. And I think that as ACL surgeries has evolved, even Bruce Ryder said, we do ACL surgery to protect the menisci. And yet, I think that's really where we still haven't made the progress that we need to make. And I look at things like the lateral root tear, which, when I was in training, that was one of Don Shelbourne's aggressive non-treatment of lateral meniscus tears. And he reported good outcomes. And now we're all trying to fix the root tears and we see them. And I don't think anybody talked about ramp lesions when I was in training either. They didn't even know they existed. But now you take a more careful look and they tend to be pretty stable. I'm wondering how much of a difference we're making compared to the kind of benign neglect treatment that we kind of managed them with, 20 years ago.
I think it's a great point. I did not find a huge failure rate of my medial meniscus after ACL reconstruction. I mean, these people, I didn't even look for ramp lesions. So are we over treating that? We might be. I would totally agree on the lateral meniscus root stuff. I mean, we just ignored those, and Don Shelbourne's data said they did well. Our Moon data, again, we didn't categorize a root tear per se, but the meniscus tears we left alone had a 94 to 97% chance of doing okay. So it is, are we just creating more work for ourselves? I don't know. It's a really good question because there is something to be said for benign neglect on certain things. Totally agree.
Well, when is you said Moon's going to have 20-year data soon?
So they're working on it. So the NIH funding has run out. They are reapplying for a renewal at this point in time. They do have a whole subset of patients that they're still bringing back for radiographic follow-up at certain sites. So at Vanderbilt, Cleveland Clinic, and Ohio State, they come back for certain radiographs to follow for joint space narrowing and those kind of things. So I do think it'll happen, but they're just trying to secure the funding to make sure they can bring them back.
The residents be happy we were not part of Moon, because I had to fill out that 50-page form as a fellow every time I did an ACL, and it really is 50 pages.
It was painful.
Yes, yeah. On paper.
On paper, right? We've gone to red cap now, but back then it was on paper. Yeah. Then you had to send them in, and it was a drag. RG?
Thanks. Can you tell us about what standardization there was for the post-op protocol for the ACLs? And has it changed what you do?
Yeah, so that's interesting. We, as a group, got together and talked about that very thing. When we started the study, half the group would put every patient in a post-op brace, and half the group did not put them in a brace. They did a literature review. There's actually zero evidence that a brace after ACL makes any difference.
A functional brace or just an immobilizer post-op?
Like a hinged post-op IKO. So it was standard for the group you could not put your patient in an IKO unless they had a concurrent meniscus tear that was treated, that was repaired. So everybody else got treated just with crutches for the first 2 weeks. And that's still generally what I do. I don't put them in an IKO after surgery unless they're a rambunctious teenager that I don't trust at school. But do you all use IKOs after an ACL? Do you put everybody in a brace, or do you not put them in a brace?
I use a IKO if there was a meniscus and a regular knee immobilizer if just an ACL.
So that's kind of, as a group, we could put them in, if they had a block, we could put them in a knee immobilizer until their block wore off. But unless they had a meniscus repair, we were not supposed to put them in a brace. And then they did have so I didn't put it up here. There's a website, acltear.info. acltear.info is kind of the Moon ACL hub site. And they actually, so as a group, we came up with a standardized rehabilitation program. It's called the Moon program for ACL reconstruction patients. It has a lot of stuff on there, including our rehab. They have risk calculators. So you can put in the patient's age, their activity level, what kind of graft you're going to use, what other stuff is going on. And it'll actually spit out a number. What's your risk of re-injuring your knee? What's your risk of injuring your other knee? So if you go to that website, acltear.info, you'll find a lot of our publications, but you'll also find our rehab protocol that was come up with as a group. And we didn't do that as surgeons. We actually drew in the lead therapists at all of our academic sites to put together this consensus statement on PT. I still use the rehab program. Yeah. It's very much driven by just milestones. You know, it's not so much time-based. It's very much milestone-based. You know, I would also say that when we put that together, we were not in the era of, aggressive testing to get back to sport. So we don't have metrics that you have to meet to return to sport, but it's very much milestone driven on just getting the patient through the 6 to 9 month recovery that they have.
So thanks, Dr. Wolf, for a great talk. And I think for the residents, it's good to acknowledge like the conversations we have every day in the office. It's pretty much from a lot of this data that you have the ammunition when you're counseling someone to say, graft choice, what are you doing? And this is a lot of work. To get 80% follow-up at 10 years is just, remarkable. And so this is the information and the kind of conversations you're having with your patients for the most part based on a lot of this study. So that's, really something that should be commended. And I feel like even with all of the data that we have, obviously ACL continues to not have a 98% success rate, right? And we're, I think, kind of in the midst of the meniscus repair, and I think that's pretty well accepted. That's a big part of this. And I kind of look at the next frontier, a little bit of like the extraarticular procedures and trying to validate and understand who the right patient is for that. Do you need to do it? When do you need to do it? How do you do it? And I'm just kind of curious when your indication is to add something with like a LET, who the patient is and kind of how you're doing that, because I think that's still not really borne out in our literature. And that's probably going to be the next 5 or 10 years of what we're doing.
Yeah, it's a great point. So none of that was included in Moon. So they were not doing that. I would say most of the senior members of Moon would say, well, we kind of went down that road and why would we do that again? So things like lateral extraarticular tenodesis, where, that was really historical surgery that was done before we did modern ACL. And now we're starting to bring it back. And to put it in context, Al Getgood, who's up in London, Ontario, has done a very big study on young people who are active that ACL reconstruction with hamstring grafts, multi-center across Canada and in Europe. And when you had a hamstring graft, or you could have a hamstring graft and a lateral extraarticular tenodesis, which is taking a small strip of the IT band, weaving it under the proximal fibular collateral ligament and tacking it down to the distal lateral femur, just proximal to your epicondyle. If you think about it, an LET, if you think about it, what an ACL is supposed to do. So an ACL is supposed to prevent your tibia from coming forward, right? It's also supposed to prevent your tibia from rotating on your femur. If you were going to design something to keep your tibia from rotating on your femur, would you put it right between the middle of your knuckles? You'd probably put it more on the outside. So the thought process between an LAT is your ACL is going to help with this. It's going to help a little bit with the rotational, but if you do something on the periphery of your knee, you're probably going to help more with the rotational aspect of ACL instability. So getting back to this study, they did a stability trial. And they found that the risk of re-injuring your ACL in a young athletic population with a hamstring graft was about 3 times lower if you had an LET plus your hamstring graft. They're now redoing that study with quad tendon and BTB. You could say our data, well, hamstrings aren't as good as BTB, so is it the graft? Is it the LET? So now they're going back to do that. So getting back to your question, I actually do a fair amount of LET. I have a 15-year-old female with a little bit of laxity that plays soccer for a living. She's probably going to get an ACL with an LET, even in the primary setting. Most of my revisions in active people get an LET, just adding something to the mix. So we're a little bit aggressive with it. Maybe, I don't know if it's over aggressive. I've had one patient that I think probably had some lateral compartment tightness because of an LET, but other than that, we haven't seen any downsides. I'm also a little bit biased in that I have a grant from the Arthritis Foundation to look at weight-bearing CT after ACL and after ACL plus LET to see if it's changing the mechanics of their knee. So I'm kind of interested to see how they do. But I would say myself and my partners are probably a little bit more aggressive than average in our young, risky patients that, I mean, the Mayo data in a high school and college soccer female, their risk of tearing their knee is like 20 to 25%. So if I have a young female soccer player, young female basketball player that I think is risky, and again, some of this is level 5 subjective, me talking to them, then we'll add an LET. It adds on 15 minutes for me. It doesn't change anything for them otherwise. It does potentially burn a bridge if they do tear their knee again. What am I going to do next time? So that's what goes through my head. So if they do tear their knee again, what am I going to do different next time? Do an ALL or something, which an ALL is the same thing, but with a graft. But we are being more aggressive that way. We'll see in 5 years if it was a bad decision.
So on that 15-year-old, what's your primary graft choice?
If they're skeletally mature, it's going to be a BTB. If they're like, I seem to have a captured market of 15-year-old boys that are not quite skeletally mature. And I tend to do a quad tendon and an LET, those folks. All soft tissue.
Going back to Moon data and hamstrings, hamstrings became very popular for a while and then kind of dropped off as we started to see some of the data. But I think it was before we recognized that smaller patients had smaller hamstrings. So everyone just did a quadruple hamstring. Nobody ever thought about a tripled semi-T. I think maybe, now quad tendons come into vogue. So I don't know if it's ever going to take off again, but maybe going to a 5-stranded hamstring is another option. And now with the LET, because you could argue, going back to I always block the guy from Australia who did the randomized prospective on BTB versus hamstring, Pinzewski. He was showing less arthritic change in long-term follow-up on hamstring versus BTB, yet theoretically there's a higher failure rate. And I wonder if it's graft harvest morbidity or something that has to do with that. And now with LET coming back into vogue, maybe hamstrings may make a comeback as well.
Yeah. No, I think so. There's a fair amount of literature. If you do a hamstring graft, you want it to be at least 8 millimeters in diameter. So our data in Moon, I didn't put that study up, but we have data through Moon, and then there's several other data points for hamstring grafts under 8 millimeters. Your risk of re-tearing is higher. I'm just in the process of submitting a paper on 5-strand ACL because there's a little bit of literature out there, but not a lot. If you actually triple this MIT and just double the gracilis, that makes 5 strands. So you kind of have 3 strands of MIT, 2 strands of gracilis. You on average gain about 1 millimeter diameter. We looked back at, I'm trying to remember, that's like 125 of those at our group. And at 6 year, our failure rate was really low. Now, these are probably not going to be my high activity level kids, but it's under 3 or 4%. So I do think for hamstring, diameter size makes a huge difference, and you can help yourself by just taking a little extra time and doing your graft prep a different way.
I had a question about the Jomar here. Great talk. Thanks, Doug. About the quality adjusted life years for these. Like live without your ACL, but it seems to be so impactful to do that surgery. I was so surprised that it was so much more, impactful than like some of the joint replacement surgeries we hear so much about. Operation of the century, quote unquote. Where do they get those points? Or is it because they're young, active patients usually, and they value those years of activity more, or what is it?
I couldn't hear everything. So what was exactly? Speak up just a little bit.
Story of my life. Yeah, I guess I was just wondering how was what built up their quality adjusted life years for the ACL patients? Like why was it so much?
Yeah, it's a good question. And certainly it's probably a little bit biased because most ACL patients are younger. So they're going to be more active. They're going to be working. They're going to, that's a lot of the quality adjust. And this is not an area of expertise to me. So I rely on Warren Dunn and Chad Mather and some of these folks that understand that kind of research. But it really is like, what is the impact on your ability to work? What is your impact on your ability to do your normal day-to-day activity? And again, if you have a laborer that has an ACL deficient knee and they can't climb scaffolding and they can't get on a roof or they can't do their job, that's a huge deal. Like most of us in this room could probably deal without having an ACL. You just stand around and walk around. We're not doing a lot of climbing and all that kind of stuff. But I had a senior partner, John Albright, who did thousands of ACLs in his career, never had his fixed. He was ACL deficient for 4 decades or 5 decades or something like that. So, but a lot of it just comes into that. Are you able to do your normal day to day? Are you able to make a living, have a job, do your activity level? Yep.
That pretty much ties into my question about copers. How do we figure out who are copers, who we potentially could not operate on? Sometimes you get in there and the knee's a little more stable than you thought it would be, or looks a little better arthroscopically. You feel guilty taking it out almost. So I think there is some data from Scandinavia about copers and people that can still cross-country ski or whatever they do. So can we ever figure that out?
Yeah, it's a good question. We didn't have any copers, and I mean, we had to include everybody, but we didn't include our non-operatively treated ACLs in Moon. I would agree with you. I think that's really hard to predict. Certainly, you see people that have an MRI that shows their ACL's torn. You wiggle on their knee, you'd never know. I think it scars in, or it adheres down to their PCL, or they just kind of have a tight knee. I think those are the people that cope pretty well. They're probably not doing a lot of cutting and pivoting. So especially in your patients that are in their, even 30s, but certainly 40s and 50s, that's a conversation that I often have. You don't need to have this unless they've shredded their meniscus or had something else going on. I think it's very much an option for those folks. The hard part is that copers are copers until they bucket their medial meniscus, and then they're not a coper anymore because their knee's locked. And that's the downside that you always kind of have to talk to them about. That something bad might happen, but a lot of people get by okay. It's hard to predict. I don't know how we do that study. I mean, they tried to do it with the Canon study up in Norway. They tried to do basically to figure out who's a coper. It's rehab versus surgery. And they had quite a bit of crossover. I think half of the non-operatively treated folks crossed over to have surgery because they couldn't cope. But that data still hasn't come out of identifying who would cope okay.
Just had a question, and we were talking about ACL reconstruction, but obviously the bear has become something that's new. Do you have any experience with that? And what do you think the role for bear would be?
Yeah, I don't have any personal experience with it. I know Martha Murray quite well. Kurt Spindler, who started Moon, is very much involved in helping push that along. I know y'all are doing some of that here. I think it's exciting stuff. We certainly see there are certainly MRIs that I look at and be like, wow, this looks like one that I wish I could just fix. It's just peeled off, or it's a perfect knee and the ligament just kind of popped off the femur. And I wish we could not take all that out. The historical evidence back, 25 years ago was that just didn't do very well. So it's, and the argument always was, well, ACL reconstruction does great. It only fails 5% of the time. Well, it fails more than 5% of the time. So part of that argument is gone. But I think it's an exciting thing. Would I be surprised in 10 or 15 years if most ACLs are being treated with something like bear? I wouldn't be surprised. It's going to take a long time, though, to convince the whole orthopedic sports medicine community to switch over to repair versus reconstruction. But I think it's an exciting, my brother, who's 3 years younger than me, tore his ACL probably 5-6 years ago, 7 years ago, something like that. And he, very bright guy, was searching the internet, found this bear thing. He's like, can I fly to Boston? He didn't qualify. I think he was too old or something at the time, but he didn't qualify, but he was all in. So I think if we find it works, there's going to be a segment of the population that's going to be all in on that. Because you're not rebuilding, you're repairing what they already have. The nice thing about bear is that the research that they're doing is done the right way. It's randomized trials, it's NIH funded. So it's good science. And, as opposed to here's my 25, repairs with a button or with a tape or something, I think we're going to know if it works or not, if it's a viable option. And everything that I've seen so far is that it's non-inferior, which means that it's just as good. They haven't been able to show it's better, but I think it's promising. What's your experience here been so far? Happy?
Yeah, so far so good, but I think for better or for worse, selection bias has played a big role in how we manage patients with bear. I'm not going to take a Rutgers athlete and do a bear unless they hold a gun to my head for it. But I think MEAC, the company that Martha started, is marketing the hell out of it. So it's getting a lot of push from patients because the marketing is going out to the public around here for sure, but I think nationally. But I think until somebody has the guts to do one on a high level athlete, and that athlete gets back on the field on national TV, it's going to be difficult for the sports medicine community to take that adoption. But someday someone's going to take the plunge.
Yeah, knowing Kurt well, and he talked about Iowa being a site, but that was what I struggled with when we were contemplating this, because the verbiage that I was getting is that you have to be willing to randomize everybody, including my starting linebacker at Iowa. And I was, so when I had those discussions, it was a bit of an internal struggle, because I'm not sure I have equipoise with that yet. Plus you got to explain it to him, right? I mean, so you'd have to explain to Shiano, and I'd have to explain to Kurt Ferentz, well, we're going to do this new experimental thing. I hope it works,
Here we go the other way. Coach Shiano will be explaining it to me. We'll leave it at that.
some sort of technology that you gotta evaluate it, figure out what do you do with this.
There's always a new thing. So there is always a new thing. And some of them are really good. So I think most of us that have been in practice for a long time, like everything, most of the things that I do differently than how I was trained in residency and fellowship, whether it's graft or technique or instruments that are available. But there's always a new thing, like a little bit like some of this meniscus stuff that we've talked about. There's always a new thing. And sorting through how you want to deal with new things is a big challenge as you get into practice, because you, like was well articulated, you don't want to necessarily, I mean, some people have to be the pioneers. So, you know, you can take things on and this is going to be my baby and I'm going to push this. You have to realize a lot of things that are push are just people trying to either get name recognition or get on the podium, or it's, you know, we always want to talk about new stuff, but always be critical when you analyze a lot of these things as to how important it is, or how it fits in your practice. It's hard.
Maybe one last about in the peak of Moon, I believe that was around when transtibial was kind of the go-to technique for ACL reconstruction. Is that true? Is most of Moon transtibial? And follow up to that is how are you doing your femoral tunnel in 2022?
So there was a fair mix in Moon. So we had, I would say it was less than half was transtibial, but this was at the height of the transtibial ACL, early 2000s. But there were still so Rick Parker and Enrich and Rick Wright and Kurt Spindler all were doing 2-incision, which, anybody see a 2-incision ACL here? Who's seen a flip cutter ACL? No? So it's an independent drilling. So there was 2-incision, which would be like flip cutter. And then there was a subset of medial portal people. Maybe Andrus might've been a medial portal person, but there were, so there was a relatively good spread. Whenever we've looked at technique based on their group, we haven't been able to drill anything out of, was one better than the other than transtibial ACL did have a higher reoperation rate. Part of that was driven by a lot of those were done using, there used to be like these suspension, almost like a bolt that people would put in the Arthrex thing. And a lot of those just irritated the IT band, so they have further surgery to go get that out. I do a medial portal drilling. That's what I've done for probably the last 10 or 15 years. Independent medial portal drilling. I drill the femur all the way through. I've not jumped on the all-in-sign bandwagon. But I do medial portal drilling. I use flexible reamers for all soft tissue, and I use just a straight reamer for BTP.
Thank you very much.
Thank you.